you. Good evening and welcome to our virtual conference, Diversity, Inclusion, and Equity, Empowering Change Within Our Organization. This virtual conference is presented by New York State HIMSS Chapter Diversity Committee. My name is Dr. Saechow, and I would like to thank all the members of our committee and chapter who work together to provide this conference for you. Alexis Balingcongan, Mary Joy Garcia-Dia, Tatiana Arreglado, Susan Dillon, Zakia Mills, Mercedes Yaman, Jessica Varghese, Alicia McMyers, Ellen Aragort, Tony Ferranti, Nick Cristiano, and Sebastian Roy. I would also like to thank our sponsor, Ellit Groups, for sponsoring this program. Now I would like to introduce our producer, Sebastian Roy, who is going to review the team functionality for this program.
All right, thank you. Hi everyone, my name is Sebastian Roy. I'm the chapter treasurer and I'll be playing the role of producer today during this event. I just want to review a few features for their attendees today. Please note that there is a closed captioning function. This is an automated function. It's a CC button that you can see usually at the bottom of your screen within the Teams window. If you click on that, you will get computer-generated subtitles for the speech today. More importantly, I think, or more popular, is the Q&A function. While we can't hear or speak directly with you, the attendees today, you do have the possibility of asking us questions using the Q&A function with that question mark like icon there. If you submit the questions at any point during our panel today, the panelists will pick and choose questions that they deem relevant to answer live during the event. Please also note that if you're viewing this in a web browser as opposed to the Teams software on a mobile device or in a computer, and you run into issues like the video freezes or anything like that, you simply need to refresh your browser and that should resolve any issues you might have. Finally, please note that the event today will be recorded and we will be uploading the contents of the recording to our YouTube channel and posting the link on our website within a matter of days, usually less than a week after the event. Finally, I want to encourage all the attendees today who are not already members of HIMSS to join HIMSS and select New York HIMSS chapter as their chapter. This helps us fund the free events like this one. Thanks everyone for attending. And then now I'd like to introduce the moderator, your moderator for the evening, Alexis Balingcongan from Connexall. Over to you, Alexis.
Thank you, Sebastian, and thank you, Dr. Saechow, for their introductions. And thank you to our audience for joining us tonight. Really appreciate it. But before we begin, I'd also like to introduce our chat moderators, Susan Dillon, Zakia Mills, and Tatiana Arreglado, who will also be monitoring any questions from the audience through the chat feature on Teams. Our panelists will now give a brief introduction about themselves, and we'll start with Pam Saechow.
Good evening, everybody. Thanks for joining us this evening. I'm Pam Saechow. I'm the CEO of Ellit Groups. I want to thank you all for being here today, and I'm really privileged to be here with a great group of panel members today. As an Asian American woman, diversity, equity, and inclusion have always been at the heart of who I am. From my youth to my healthcare technology leadership roles at Sutter Health, New York City Health and Hospitals, Cleveland Clinic, to forming Ellit Groups. It is such an important part of healthcare technology for leaders to be able to develop and enable technology to work in our patients' favor and provide options to care that they truly deserve. Thank you.
Dr. Dia?
Hi, good afternoon, everyone. Thank you so much for having the opportunity to participate in this very important topic. I am the president of the Philippine Nurses Association of America, representing 55 chapters in 43 states across the United States. We are an organizational affiliate of the American Nurses Association and also a member of the National Coalition for Ethnic Minority Nurses Association, which includes 4 other organizations, which are the Asian American Pacific Islander Nurses Association, the National Alaska Native American Indian Nurses Association, the National Association of Hispanic Nurses, and the National Black Nurses Association. My full-time job, of course, is the Program Director for Nursing Informatics here at NewYork-Presbyterian. And I have been passionate in my work in the community, serving on equity, diversity, and inclusion as part of the steering committee for the Future of Nursing campaign, and also as a past member of the National Advisory Council on Research for Asian American, Native Hawaiian, and Pacific Islander Health. So I'm more than happy to participate in tonight's discussion. Thank you.
Thanks, Dr. Dia. Next is Anthony Fortenberry.
Hi, good evening, everyone. My name is Anthony Fortenberry. I'm the Chief Nursing Officer at Callan Lord Community Health Center. Just a little bit about Callan Lord. We provide healthcare and related services that are targeted toward New York's LGBTQ community and people living with HIV. We serve about 20,000 patients out of 3 locations in Chelsea, the South Bronx, and most recently we just opened a location in downtown Brooklyn. About a third of our patients identify as transgender or gender non-binary. About a quarter are living with HIV. Generally speaking, about a third of our patients are uninsured. A little bit about myself. I've been a nurse for over 15 years. I specialize in LGBTQ health, quality improvement, and DEI work. Prior to going to Callan Lord, I worked in EHR implementation at health and hospitals many, many years ago. And I'm really excited to be a part of the panel this evening. Thanks so much.
Thank you, Anthony. Next, we have Michael Wheeler.
Hi, everyone. I'm delighted to be here today with you. Michael Wheeler. I'm founder of Michael Wheeler Diversity, a consulting firm specializing in diversity, equity, inclusion, and human and organizational performance. I've dedicated my entire career to this work. It's a mission, it's a passion for me. In the early 90s, I was at the conference board where I launched their Center of Expertise with original research reports, launched a national conference, which still goes 20 years later, and also launched one of the nation's first executive diversity councils. I've been a leader within corporations. I was Director of Global Diversity and Inclusion at Merck and Chief Diversity Officer at Omnicom Media Group in New York City. So looking forward to our conversations this evening with you.
Thanks, Michael. And last we have Kevin Moore.
Hi, everyone. My name is Kevin Moore, and I am a nurse. My title has changed. I just got a promotion last week. Yay! So I am now the Assistant Director of LGBT Clinical Services at NYU Langone Health. It's an unusual role for nursing. I am clinical, I am administrative, I am managerial. I work in HR, I work in hospital policy, I work in education with nursing, and I've also done quite a bit of work in informatics. So it's all incorporated. We have a very active gender affirming program at NYU. Last year we did almost, I think, 700 surgeries, and it's just growing and growing and growing. And I'm currently getting my doctorate and master's at Rutgers in nursing leadership. And prior to nursing, this is a second career. I've been a nurse for about, oh my God, 10 or more years, and I was an actor for 20 years. So perfect fit.
Thanks, Kevin, and congratulations on that new promotion.
Thank you.
So I think we'd like to begin with our first question, which will be directed to Anthony Fortenberry. And the first question for Anthony is, as the CNO of Callan Lord, how have you been able to become the global leader in LGBTQ+ healthcare and provide a resource regardless of socioeconomic backgrounds?
It's a great question. I will do my best to try to give an overview of our programming at Callan Lord. We generally focus on building an inclusive environment through empowering staff. by using continuing education. We provide training in LGBTQ health, transgender and gender non-binary health, and sensitivity, diversity, equity, and inclusion work, specifically anti-racism work. And we do this from the first day of employment. So we have a full 2-day new staff orientation that includes all of those topics. And then on top of that, we do a mandatory 2-day training for all of our staff. It's really focused on anti-racism work, and it's very interactive. And so this is a huge investment for the organization, but it really helps to create a culture that supports diversity and promotes inclusivity. The other thing that we do that I think is really important is provide clinically specific training related to, medical mistrust in communities of color, which was our most recent one as a result of issues with vaccine uptake among the communities that we're serving, as well as gender affirming surgery support, and even other kind of like interprofessional trainings such as microaggressions as an example. These are all kind of interspersed throughout the year and provided on an annual basis. We also really use a strategy around collaborative leadership. So our DEI initiatives are led by an interdisciplinary team that includes both organizational leadership and frontline staff, which I think is really important. We also have a very active community advisory board, so I think it's also important to ensure patients' voices are a part of this process. But the committee organizes and facilitates affinity groups. It creates a space to discuss and address ways in which race impacts our policies and the care that we're providing for patients. I also want to add in, I think addressing the intersectionality of race and LGBTQ identity is a really important component of this work, particularly for the patients that we serve. To further the collaborative leadership approach, we also kind of lead by committee when it comes to our clinical services. So our HIV services, our TG&B services, our sexual reproductive health clinic are all led by an interdisciplinary team that includes administrative staff and clinical leadership that work together to promote what we like to believe is a more patient-centered workflow, because the people that are actually implementing those workflows are part of the decision-making process. I think it's a really important way in which we ensure DEI work is infused both into the way in which our staff interact with each other and also in the care that they're providing to our patients. In these committees, I will also add oversee things like environment of care to make sure that like everything from posters in the building reflect the patients that we are caring for. We want patients to see themselves and identify with imagery around the clinic. It also, things like gender neutral bathrooms and signage and intake forms all have the power to make a patient feel seen and appreciated, or can make them feel discriminated against. And particularly for our patients and for LGBTQ people generally, they've often experienced discrimination in the healthcare setting. And so building that trust and ensuring that patients have a safe space to access care is a top priority in every aspect of the clinic, from facilities and signage to the care that's happening in exam rooms. And I will end with just saying another piece to this. Speaking of forms and templates, I really wanted to mention the importance of health IT in partnership with TG&B clinical leadership. It is such an important collaboration. When you think about clinical decision support considerations, printed forms, insurance considerations, pronouns, and laboratory interfaces, right? All of these areas have the ability to either ensure gender affirming care or undermine patient trust and promote discrimination. And so it's an ever-present piece where we have to be super vigilant. Every EHR upgrade, every new lab interface requires a review of all of these forms, because what we don't want to happen is a patient get a printed form that has mispronounced them or misgendered them and undermine all of the trust that's been established between them and their primary care provider. And so in that partnership between our TG&B committee and Health IT is a really, really important piece to this work as well.
Absolutely. It's a multimodal process and a collaborative one, right? I think my next question for you, Anthony, is that, how has Callan Lord also empowered change from, let's say, a policy or a legislative perspective?
So we are very active in our advocacy work around this. I think, we certainly encourage all of our staff and patients to get engaged in advocacy work. And so I think health policy should be something that every patient is engaged in, because these policies affect their everyday, the care that they receive every day, right? So we have advocacy days. We rent a bus and take patients and staff up to Albany. Well, we used to go in person, and maybe we will again one day. We also organize Hill visits in DC. I think it's really important for our legislators to meet with our staff and our patients and really see how these health policies are impacting people's everyday lives. I think it's so impactful. I also am the chair of the National LGBT Task Force. That's an arm of the National Association of Community Health Centers. We really promote health policy and advocacy that ensures, right now, I think a particular concern for us is data collection. One important strategy that we implemented a few years ago was around mandating sexual orientation and gender identity data as part of UDS. Ensuring that this is a mandated piece of information that health centers are collecting and promoting allocation of resources toward addressing those disparities for our community is so important. Without the data to support it, it's so hard to get legislators to allocate funds. And so that was a huge priority for us and something that we continue to do today. In fact, just I think 2 weeks ago, there was a great article in the Washington Post about data discrimination specific to COVID-19. We know that this population experiences stigma and discrimination that impacts their ability to access health services. And in many ways, it impacts the transgender population most. Yet there is very little data to substantiate that, right? And so it's super important, I think, that we advocate specifically for TGNB data collection related to COVID-19. We do know that LGBTQ people are twice as likely to work in frontline jobs, such as food services, restaurants, retail, healthcare, and yet we don't have the data to support how COVID-19 is impacting this population, and therefore not allocating resources to address it. So it is a real problem and something that we've been doing a lot of advocacy around specifically lately. But of course, I do want to say we don't want to force anyone to have to self-identify as LGBTQ if they're not comfortable. What we really want is to ensure that healthcare staff feel comfortable helping to explain what these identity questions mean for patients, ensure that appropriate documentation and reporting is happening, and most importantly, promote an inclusive and supportive environment where no one is intimidated or in fear of discrimination for how they identify. Thank you.
Absolutely. Thank you so much for highlighting, equitable healthcare platforms that also provide high quality and culturally responsive healthcare services. I think my next question is for Kevin Moore. So Kevin, how has the use of electronic health records in a hospital created a digital divide, and what have you done to help improve it and provide a sense of inclusivity?
Well, first of all, I just want to say, Anthony, listening to you, it's like, oh, every time I hear you speak, I get so inspired by you. I met you actually at a Callan Lord event. Yes, okay. So Nathan and right, okay. So he's so great. So wow. So I've seen such a, prior to my role that I have now, I would say that when I thought of informatics, I thought, oh God, why would anybody want to go into that? And now I'm so inspired by it because I've seen it call a marginalized population into a conversation. And NYU is a large institution, and we worked really hard with EPIC, and I believe I think we were the first institution in New York to have gender identity and pronouns in the clinical header, which was fantastic. It was so inspiring. It was so great. It reduced people being misgendered by almost 80%, at least the people that told us, right? So that was great. So where is the divide? What I find is that it's a structural issue. It's beyond, so I can come in, and it's great that I can put your chosen name and your pronoun, your chosen name and your pronouns in the clinical header, your chosen name on your wristband, in your discharge paperwork, but not in pharmacy, not in labs, not in and dietary. And so there's these structural issues. And what happens is that then a structural issue is also, is every person that comes in going to have a nurse or a clinician that is educated around especially transgender and gender non-binary culture and language? And so if I don't, what happens if I'm misgendered? And then I have to correct the clinician, right? And then the clinician is, there's almost a dichotomy change, right? Because now I'm telling the clinician, once again, it's very common, trans and gender non-binary people talking about and explaining who they are and why you using the wrong pronoun is, as I say when I educate nurses, is you need to take it as important as a medication error. That's how important it is. And then all of this, the structural issue, the lack of consciousness sometimes, all comes back on the patient, right? So unless we get under these structural issues and all of these structural issues, it's like putting Band-Aids on top of everything. It's super inspiring to watch us move forward, but it gets pretty aggravating sometimes, to be honest with you, at these structural issues that I really am pushing to change. And so, but I'm going to keep pushing, and I'll push as hard as I can. But that's where I find the divide is. It's great, but it's sort of like, here's your 30% or here's your 40%. You know, I find that it's constantly advocating, and I'm happy to do it, but it's a little bit frustrating.
Absolutely, and I know that you know, you spoke about structural and communication and education issues. How do you think, let's say in your new role, how have you empowered change within an organizational structure to create more roles like yours within a hospital setting?
So what a great question. Boy, do we need a role like this? I think we need it for every service, but the truth is, do we really need it for LGBTQ people? Because it's standing in advocacy and empower in a way that I always say, like, I like to call people into the conversation, not out of the conversation. So I'm not there to point my finger at you. I'm there to show you. I want you to see. I want you to, just like Anthony said, I want that patient to know that we see you. So one of the things that I'm developing right now that I'm pretty excited about, there's two things, but this is, we're calling it a subject matter expert. And Anthony, it used to be called the champion model. So the subject matter expert is now going to spend time at outpatient plastics to see what it's like for a patient to get a consult on gender affirming surgery, what the follow-ups are like, because staff nurses don't really get to see that. And then they actually get to observe surgery, and they spend time with me and really get to know the culture and the language, and so that they become models on their floor. In fact, I had one working today. One of the clinical things I do is I work with patients getting gender affirming care and make sure that before they leave, depending on what care they've had, that they understand what they need to do and who they need to call if there's a problem. And we follow them really closely. So one of the nurses was working with me today and helping me get patients ready to go home and making sure that they were knowledgeable. That is a really exciting piece of what we're doing right now, because it's really empowering other nurses on the floor. And that is a culture change, right? What happens is people they might hear someone, say, for example, they might hear someone maybe be in the hallway and misgender someone, and they'll be like, actually, you know, you should stop. You need to actually, this is what it is. This is why it's important. So they become little champions for you all in these places. And that's where culture change starts to happen. There's a lot of nurses at NYU that feel really passionate about this work, and that's really quite exciting. The other areas, it's not just nursing, it's calling the other disciplines in as well. One of the most exciting things I think I get to do is we have a surgery class where we actually have a class for people. We're going to expand it to all our surgeries, but for people that are having vaginoplasty, that's for transgender women, and we teach them the whole process, what it's going to be like, what they need to have ready, what it's going to be like in the class, in the hospital. They meet integrative health, they meet pelvic floor physical therapy, they meet the inpatient plastics team, and it really decreases the patient's anxiety. And I'm actually gonna, Anthony, I'm doing that for my doctorate, by the way. So I'm studying it to get data on it. And data is really what we need desperately. Lastly, I didn't mention this in the beginning, and I think this is really important, and Anthony mentioned it, having voices with you at the table that are trans and gender non-binary. I learned when I first started this work that nothing for us without us. And so I constantly try to remember that. I started a trans and gender non-binary patient family advisory council that consists of people of different gender identities, different colors, and then also parents of trans kids. And so we have a really diverse voice, because when you work at a place, you become numb sometimes, your eyes don't see as well. And so it's really a great perspective to have from these people who help you tremendously kind of develop this, because you don't want to be the institution that says we're doing it this way. Actually, we're going to do it the way that you feel we need to do it, because the need is from you and we want to fulfill it. So that's really super important to have those voices at the table, to make sure and that you're putting trans and gender non-binary people in positions of power and authority, and making sure that they get paid well.
Absolutely. Absolutely. We need more positions and roles and representatives like in your role. Absolutely. The next question I'd like to direct is to Dr. Dia. And Dr. Dia, as a member of the National Advisory Council on Research for Asian American, Native Hawaiian, and Pacific Islander Health, what have you discovered through your grant projects?
Thank you so much for that question, Alexis. First of all, as a disclaimer, I acquired my subject matter expertise due to my engagement as a volunteer in nonprofit organizations. Therefore, my point of view is really coming from my role in community organization and professional associations. My journey actually started simply helping in the community, providing blood pressure screenings, cholesterol, and glucose checks as part of our outreach through Kalusugan Coalition. Kalusugan means health in Tagalog language, and in partnership with the NYU Center for the Study of Asian American Health, together with faith-based organizations. So we were just reaching out to the community as part of our work within the Philippine Nurses Association of New York Chapter. So in that years of volunteerism, I learned to understand the word model minority, wherein Asian Americans are stereotyped and promoted in the media as hardworking, affluent, and healthy. Yet when I provide community screenings to these people in my community, they work more than 2 jobs, right? They're not rich. Majority work as domestic workers or caregivers. Some work in groceries and restaurants, just like what Anthony had cited in his case. I also learned that due to the nature of their work and habits acquired through the years, such as they're not sleeping well, because of the nature of their work, they're not able to really do targeted exercises. They have poor choices with their diet because, of course, with the fast pace of life, it's easier to just buy fast food versus doing home-cooked meals. So these populations are really at a higher risk for cardiovascular disease, diabetes, and respiratory problems. So as I try to expand my understanding on health equity and disparity in Asian communities, I came to realize that this model minority myth have a greater impact on research, which also ultimately impacts funding within community-based participatory research and engagement. As you know, when we were trained as nursing informaticists, we always hear the quote from Norma Lang that if you can't name it, you can't practice it, you can't teach it, you can't pay for it, you can't research it, so you can't really put it into public policy. So it's interesting, because of this talk, there was a recent editorial article from JAMA dated February 22 on the reporting of race and ethnicity in medical and scientific journals, highlighting the critical importance of terminology, usage, and word choice, especially when describing people and when describing race and ethnicity, in relation to articles that addresses disparities in medical education, research, and healthcare. And it also highlights the deep-rooted inequities. So as Asian Americans, we comprise the fastest growing racial ethnic group in the US. Between 2000 and 2019, the numbers almost doubled from 11.9 million to 22.2 million. So as the past chair of Kalusugan Coalition, I usually would receive an outreach from another community-based organization to support each other. For example, the Korean Community Services of Metropolitan New York reached out to us way back in 2017 if we are interested to apply for a joint grant for mammogram screening. So my second disclaimer is that I am not a PhD graduate, but my doctoral education from Case Western is rooted in research, and I do have a basic understanding in facilitating research due to my training and mentorship under Dr. Joyce Fitzpatrick, who is the director of the Marian Shaughnessy Nurse Leadership Academy, and also from Dr. Elizabeth Madigan, who is the chief executive director of Sigma Theta Tau. So with these mentors, what I discovered in applying for research grant is that it's very tedious. The justification for the research fund requires supporting evidence from existing studies on specific target population before you could even proceed in crafting your letter of support. So when I Googled to provide references in order for me to justify the grant for mammogram services, there was a limited number of articles focused really on Filipino women with breast cancer compared to other races or ethnic groups. So I encountered this data limitation, but this did not really stop me. I know that the model myth minority undermines the importance of data to specific group, which affects diversity and inclusion. So it's almost like going through a rabbit hole. The lack of adequate data impedes the grant funding, which is sometimes very competitive, and your chances of approval might be lower compared to other population. So there is this downstream impact from policy or systems in the perspective of Asian women, right? For that matter, whether you're Filipino, Chinese, Korean, South Asian, or Vietnamese, women are not well understood in that regard. So this further creates disparity with access, treatment, interventions, and outcomes. So if you think about this from a community perspective, the data aggregation being lumped under Asians limit our capacity to provide tailored interventions based on one's language or your cultural norms or beliefs and traditional practices. So all of these learnings really kind of like help me be more passionate in what I do in the community. And somehow we need to partner with other organizations or academic medical centers to further our cause to be included.
Absolutely. It's about partnership and getting the word out, right? And Dr. Dia, how has your work as the past chair of Kalusugan and current president of PNAA helped shine a light and address that underrepresentation of minority health and research, equitable health policies, and access to healthcare services, especially now?
So just like what Kevin had mentioned, this work, because of the publications, we were invited actually to be part of the process in trying to promote the All of Us research way back in 2017. And one of the things that we sort of like noticed right away is the marketing communication materials. So they're trying to engage 1 million population, right, to be part of this research project. But the marketing materials did not include people like me that would look like me. So we immediately, have like a work group in trying to, how can we make this more culturally tailored for our community? How can we be represented in research that will really impact future treatments and care, especially if we're going to be looking at precision medicine, genetics, genomics, and also incorporating social determinants of health, right? And the environmental factors. So we are glad that they listened. We were able to at least create some materials that would include faces of Asian Americans, make messages that we are needed to be included as part of that discussion, and because of that, we were able to participate. And in fact, one of our community leaders was part of the video that was included as the kickoff for the All of Us research program. One thing, though, that I also realized that aside from the terminology usage with the electronic health record, the data aggregation and underrepresentation, we know that we need to continue our work much more during COVID-19. I mentioned that we work together with the National Coalition for Ethnic Minority Nurses Association. So we're able to put together our heads and provide an article on how to provide care in a culturally congruent manner for minority populations. And this was published in the Transcultural Nursing. We also issued position statements with regards to how can we make our morbidity and mortality rates be more visible. Because we understand that when we try to look at large databases from CDC, we're still lumped under Asians, but we know that based on the news, 30% of Filipino American nurses were affected disproportionately with COVID. And that's really where we are right now in just trying to put our heads together and try to trace the data. And hopefully through our advocacy and collaboration with other Filipino American community, we could really surface up this information. So this could guide the policy process, especially as we further our cause with the vaccine distribution and administration.
Thank you so much, Dr. Dia, for all the work that you've been doing, especially shining a light on our Asian community and how healthcare can be affected to specific communities as well, and the importance of collecting that data so that we can expand on our research. Thank you so much for your work. I think next question I'd like to ask is for Pam Saechow. And as we discuss the need to shine a light with representation of various communities, Pam, how have your experiences as an Asian female shaped your career in healthcare technology?
Wow. You know what, the one answer that comes to my mind all the time whenever I get asked a similar question about what experience has shaped you to be who you are, and especially how you carry into the healthcare industry, one person always comes up to my mind, and it's my grandmother. I was so blessed to be adopted at a very young age, and I lost her before I turned the age of 1. She was a single mother raising 8 children. And unfortunately, she had to see 4 of her children pass before her. And she's like, no mother should ever go through that. But she is such an amazing person. And what I would say is that she was such an influential leader. And living in the Laotian community, she was actually the medicine woman before modern medicine became the big thing. And so she would make herbalists and take care of people. And I think growing up watching her, I don't normally have as much of an appreciation at a younger age. But when we migrated and came to America, coming to the United States as a refugee, we really settled in areas where we wanted to have some consistency in culture with others as we began to assimilate into the American society. And my grandmother was really big about pushing modern healthcare. She was such a great pioneer, and she really pushed modern healthcare. What she learned very quickly as I learned English in my first year of being in America was, I know how to help people. We don't speak English. This girl, she speaks English. And so I ended up being in the community, helping people interpret, call their doctor's appointments, make visits, take them to physician appointments. When the insurance denied them on something, I had to call and help them with that. They didn't understand the language, couldn't read the things. And so what I learned in that process, and I actually got fed up one day because I still remember the story with her, and I'm like, grandmother, I have homework, right? We came to America for a better life. I have to get good grades, and I'm spending so much time at night helping all these people during the day. I don't have time to do homework. And I will never forget what she said to me. Young lady, and this was actually in Laotian language, which is very harsh. And she said, listen to me, and you listen to me very well, and you never should ever forget this as long as you live. Do you hear me? I'm like, okay, I'm in trouble. And she said, you have a gift. Your life did not get saved to be here in this family with me, without having a gift to make a positive impact? Do you know what a gift it is to help people? They're scared. They don't know how to get their health care. People send them a letter, leave them a message. They don't know. They owe bills. They don't know. And primarily, they were Medicare, Medicaid patients at the time. And it dawned on me at that moment, the appreciation that I needed to have to realize, you know what? They're very vulnerable and they're scared. They need help. I am their advocate because I can interpret and have those conversations. Through all of those experiences, I learned medical terminology, whether I like it or not, really start learning medications and go do things. And so when I started my career after graduating high school, and I was very, privileged to start in Sutter Health, I started in the pharmacy technician right out of high school. During Y2K in 1998, I was actually recruited to join Y2K in the IT department. They were looking for people who knew operations, clinical, and I was actually planning to become a pharmacist. And they said, we need you to come join IT. And I said, I don't know anything about IT. Oh, gosh. I don't know what to do. I know how to upgrade a picture system, that's as good as it gets. And they said, no, it's important to have somebody join IT who can appreciate some of the frontline workflows. And we're actually looking for somebody that can kind of do pharmacy workflows, build, configuration, all of that. And so I joined IT, and I think the first 6 months of my role, I went back to my grandmother crying, going, I think I made the wrong decision. I gotta go back to my old job. And she said, I don't think that's true. Your light bulb just hasn't come up. And I realized when I was doing the build, I'm like, oh my God, when I was on the other end on the pharmacy, I'm like, I could build all these medications and tag this and make this more efficient and do this. And guess what? The patient would just order it online, come pick it up. It became really exciting to me. And I think from that moment on, couple of things that I really keep in mind on how I really bring that to bear, my experience into healthcare technology. Number one is I want to make sure in IT that we don't forget that patients really are our purpose, and that experience of taking care of people, making sure they're not vulnerable or scared to get the care they need and to get their treatment, and no matter what they're going through, to really be mindful that that's the audience I'm here to take care of. So if any of you ever watched this YouTube video, right, you probably have heard of it, Cleveland Clinic's empathy, the human connection to the patients. For me, that's really important. It resonates with me. So when I became a healthcare IT leader, the biggest things I do to incorporate into our daily life as a culture is share patient stories during our meetings for our departments. I tell my team, facts tell, stories sell. Remember who you're here to serve. The other thing I would do is when you're building something, I recruited a lot of people that came from the operations area. So 30% of my team building the EHR came from operations, knew the front line, could work with docs, nurses. The other percentage did not come from healthcare operations specific, but they had IT knowledge. They would go shadow the various departments they were supporting. I want you to observe, I want you to ask questions, I want you to understand what you're there to do. And so I really feel like those are some of the experience that I really do bring to bear into the IT space of never forgetting who you're serving and having that humility and empathy for why we're here. And our job, I tell the team, I use this word duet, and I actually stole that, to be honest with you. I borrowed it from Epic. Duet, this was years ago before they changed the slogan, but I loved it because it resonated with me. In IT, difficult on us, easy on them. That's our job. I know they're asking you to do hard things from operations, but they're dealing with the patients. So we are going to take the hard work to make it easy for them. So that's really kind of my motto. Thank you.
Absolutely, that's amazing, and we can tell that your grandmother has had a lasting imprint on you, and that your work is also leaving an imprint on others. So I thank you for that. I think my next question, Pam, then is, you spoke about your grandmother, you spoke about your experiences, in your community, but what do you think is the best advice you can give women regarding the advancement of their careers?
Oh, wow. Well, I would say my career started at Sutter, as many of you knew, and so I grew at Sutter Health, both in my skills in leadership as well as my knowledge in healthcare technology. And one of the biggest thing I would say, self-reflecting on this particular question, is grit. And I describe that as grit is my passion, sustained persistency of making sure that it's applied toward long-term achievements. It really does combine what I call resiliency, your ambition, and your self-control when it comes to the pursuit of goals that could take months, years, or even decades. And so for me, I would say one of my mentors always tell me self-reflect. And my grandmother would say, before you go to bed, check yourself. Look inside your heart, were all your intentions good and what you did today, Pam? Number 2, go to bed, don't regret what you did. And those always resonated with me as well. And so I really think as I grew up in my career letter or advancing career, it's quite, I would say it's kind of like very opposite of what you grew up with as an Asian woman. It was like, be submissive, keep your voice low, don't speak out too loud. I remember because my dad actually remarried much later in life. My stepmom would say things like, nobody's gonna marry you, you know, Pam. That was hard. Look at my daughters, you know, and I'm like, you know, and my grandmother was like, don't you dare. Don't you dare. You have a voice, you need to use it, just use it for good things. And her thing to me was always, and I think this is kind of what I would just tell people in general, is that never be afraid of having goals and dreams. I think that's important. And never be afraid to just learn things. You know, I grew up in my career and I literally grew, I would say, from bottom up. And I was so blessed to be given so many eclectic projects. Oh, you're going to do a data archiving, you're implementing the EHR, you're building a service line for shared services. And I never once thought about the end game. Oh, I'm going to be a manager, I'm going to be a director. I was just like, do good work, go work hard, just do it. I'm learning so much and I'm just so happy. And then organically, people realize the passion you have and what you do and that you're going towards a purpose that's so much greater than yourself. I think that's number one for me. I would tell people that lifelong learning is so important. When you think you make a mistake, that mistake is really to teach you a lesson. And it's only a mistake if you're not going to learn from it. So don't be afraid. And the one thing I would also say my grandmother said to me that I love so very much, she's like, don't ever be afraid to lose your job, Pam. When you're so afraid and fearful of losing your job, you lose your voice of doing the right thing right. And even when you're doing the right thing right and the consequences weren't good, you're gonna look back one day and you're still gonna be proud of yourself because you don't compromise your values. I would say don't be afraid to ask for help, make your intentions very clear. I know there are people, in fact, I lived through this experience myself where I told my boss that, hey, I have 200 people reporting to me. I've been doing this for 1.5 years and I was so scared to work up the courage. Don't you think I deserve a promotion called the director role? These people are coming in with directors. And oh my gosh, I had such a whiplash. Like, how dare you ask? I went home kind of like crawling away a little bit. 6 months later, I got the promotion. What that taught me is know your value. Don't be afraid. And if you don't make your intentions known, how would people know it's not just going to come to you. Work hard at it, have integrity, you know, and just don't be afraid to ask for those things. Just know your value. That's my thing. And don't think your job is to sit there and wait people to give you stuff. You give to get and don't give because you think you're going to get something else. Those would be some of the things I would just think on my own personal career advancements from coming in as a business analyst 1 to becoming a CIO, is that those values I carry with me really have proven good. And that's what I would impart to other women who want to advance themselves or just anyone in general.
Absolutely. I get fearless voice, using that grit and determination and just not being afraid to know your worth and be a representative, you know, for your community. You know, thank you for that. And thank you to your grandmother.
Oh yeah,
for
God bless her. That's all I have to say.
She definitely, you could feel a sense of her in your passion and work. So thank you to her. Thank you to you. I think the next question then, I'd like to, let's say, pivot from an operational standpoint, right? And this is directed to Michael Wheeler. And, you know, Michael, you have over 2 decades of experience working across sectors and industries. What nuggets of wisdom might you be able to provide us based upon what you know works to ensure we are successful and impactful with our diversity, equity, and inclusion strategies and tactics?
Well, I have to say, all of you have inspired me so much today, and you've really modeled what I'm going to tell you. So I'm going to kind of reinforce what you've been doing, and it's really moving, inspiring, exciting to me to see this. So, one, Pamela, you shared a story, and something that's very important to this work is the head, heart, hand model, and you really showed us heart, and you through your personal stories, and there's such power in that. And what I find very often in organizations, people can be very cognitive. That's important. There's skills, there's knowledge you need to have for this work, but you also need the heart. And not only have heart, but pay attention to people's hearts. Take care for those people. So there's the heart, the head, and then the hand. What do you do with this? How do you do? So people get stuck in this head place often in certain environments, but you got to move into the action. And that's about leaning into discomfort and making things happen and bringing it home. You know, from something up here, pie in the sky, oh, diversity drives innovation, to really doing it. So head, heart, hand. Keep that in mind always as you're doing this work. I think too, Mary Joy, you said something about being careful with your words. And these words, diversity, equity, and inclusion, are all over the place now. When I started this work, they were emerging terms, and they've evolved, and we've added words. But I can say I've gone to conferences, spoken to people. You can't ever assume everybody means the same thing. So it's not that we need a universal definition, but in your organizations, be clear. What does diversity mean here? What does equity mean? What does an inclusion mean? And put some metrics and behaviors behind it so people know what it looks like. And I'll just share, you know, one of the ways I think about diversity, it's not something you do, and I hear people say I do diversity, but diversity is a fact. It's part of everything we do. It's in our world, but it has dynamics that come with that across race, gender, our differences, with our similarities. We have to understand the implications on what we do and how we do it. I used to work for Merck, as I mentioned earlier, and they have this wonderful motto, what we do matters and how we do it matters. And in the work that you all do here, this is life-saving. This is about lives. It's very real. So understand the implications of these dynamics of how bias comes into play, how conflict, exclusion, all these factors have implications for what we do. So just keeping that in mind, you know, equity inclusion is an important part of closing gaps and providing opportunities for people, making people successful. And I think too, you know, with those words, just being very specific about what that means. The other piece I think from my experience is really important, just to be cognizant of context. So you've all shared very specific examples relative to the context of your work. It brings it to life, it brings it home, and it changes systems and how you do things when you put it in the context of what you do every day. So I've seen wonderful presentations, wonderful talks on diversity, equity, and inclusion, but you got to bring it home to where you're at with people every day. The other thing too, a colleague of mine used to talk about touch points, and I love that, and I've heard that over and over today in the presentations. Pay attention to those touch points for patients, also for employees. What's that experience they have from the time you interview for a job, the image you see, to your first day at work, to your career path? Know the touch points. I think, Anthony, you talked about posters and information so patients can see themselves. I love that. You create those touch points where people feel good and know they matter and they see themselves. That's very powerful. Related to this is really specificity too, to everything. There's a quote that I use, and I just keep it on my bulletin board, from Yvette Bowden. She used to head diversity from United Airlines, and she said, diversity is a value stream that impacts every way you do business and interact with people. It's a business processes or any organizational process open to diversity, equity, and inclusion, not just about diversity, equity, and inclusion processes. So again, I just saw endless examples here, which is very powerful, but I think that's a good reminder. Again, how are we doing what we're doing and how are we putting the lens on that? And thinking about all those dimensions of diversity, LGBTQ, women, Asians, Black, Hispanic, people experience the world differently based on their identities, based on who they are, and it's important that we understand that specificity. So I've seen during Women's History Month, too often white women are up there, women are diverse, and not all women experience the same thing. They experience a lot of similar things, but we have to look at culture. So I call it diversity of diversity. I always think about within the LGBTQ community, with the Hispanic community, the diversity of diversity within those groups is important. Kevin, you talked about structure. I think both as you approach this, really create a structure for diversity, equity, and inclusion, not just programs, but build something. So when I was at Merck, we built a team made up of our employee resource groups, of our business leaders from across the different areas of the organization, some research labs, from manufacturing, from strategy. We brought in an HR team and brought everybody together to look at, they were the feet on the ground, the people making things happen. And you build a structure of people doing this every day, and it engages them too. So it's a lot different than just telling people or teaching, but engaging them, and that's really critical. It ties back to the point, Kevin, you mentioned about not about us, without us. That is so critical, and so often I've seen decisions made. Find people, make sure the voices are in the room somehow. But one of the frameworks I'll share that I think is core way to think about this, I call it a strategic framework. One is build. How are you building your teams internally? Because at the end of the day, it's how you serve your patients, your customers, whoever they are. What's the culture you're creating for people and their experience? It's one thing to bring people in, but make sure they're in a place where they can thrive and be successful and grow no matter who you are. And that makes the difference too for the culture that people experience when they come into your organizations. You got to build the knowledge and skills. This is work, it's tough. You got to be ongoing cognizant. At the end of the day, this really helps you be better at what you do and what you're trying to achieve. You support that with good communication, education, accountability too. I could go on with a bunch of things here, but I would just say make sure that your intent has the impact you want to have. And that's really, I'll just wrap up with following this through, connecting the dots through everything you do. And at the end of the day, when you're clear about why we're doing this and where we want to go and how to get there, it's going to make all the difference in the world.
Absolutely, absolutely, Michael. 100% with the diversity of the diversity, right? And so I think I want to ask you next, when you speak about diversity of diversity, or when you have women speaking on diversity, but yet it's just of a certain type of women, what about in your experiences, how have you been able to help clients successfully include, let's say, millennial leadership, or have you seen an increase in millennial leadership?
Yeah, it's interesting. Thank you for asking that. So I'd say the last few years working with organizations, millennials are the hot topic. And what's been fascinating to me is absolutely they're growing, they're changing the way things are done at work. But I'd say we have to be careful not to stereotype. We have to be careful not to assume that all millennials want the same things. We have to be careful to think about millennials over time, over their careers might change, people change. So organizations I've seen are getting very dramatic. We got to change everything, change our benefits, blah, blah, blah. Yeah, things have to change, but be careful with that. I got involved, was invited to be part of a group on millennials. What are we going to do in this organization, and how are we going to bring on millennials, make sure they're successful? There were no millennials in the group. So back to the not about us, without us. Let's get them in the room. Something that I've done, and I guess the point I would make here, it's important to understand what different generations need, but it's really cross-generational issue we're talking about here. We have 5 generations in the workplace, and we all have different backgrounds, some similarities, but that's the real issue here. And just like diversity, paying attention to what people need at the end of the day is really important. Understanding who they are. Back again to that diversity of diversity, millennials are very diverse. They're a lot more informed around these topics than we have been historically. And one of the most powerful ways I've been able to work with this, and I've done this in a number of organizations, is have a little workshop, and I've called it a diversity dialogue. There's probably a better name for it, but it's getting real people in the room. So it's not Michael Wheeler out there lecturing on, millennials and other generations, but getting across a panel of different generations talking about their experiences and sharing some research highlights, some facts. There is data and information out there, but hearing from real people and getting real people involved, having a dialogue has been very powerful, because in real time, people own it. It's kind of back to that head, heart, hand. They get it when they hear the stories, when they understand what they can do. Simple thing that's come out of these conversations. Millennials like feedback, not just once a year, but talk to me, once a month at least. Let's have some conversations. Well, not everybody likes that. There's something to be said for getting feedback and information throughout your work. So that's a few of the ways that I've had the opportunity to work with millennials and work with others, and as we work across our generations.
Absolutely, and I thank you for that, because I'm part of that, that group, right? That millennial leadership group, and in my experiences, there are perhaps roadblocks or doubts or stereotypes in terms of, how much grit do you have to want to be successful? Do you want to be in those working groups? So, I thank you for speaking to that and, just shining a light about that. I think what we're going to do now is we have some questions coming in from the audience, and I thank Susan, Zakia, and Tatiana for vetting some of those through. And I'd like to direct a question for Pam. And there was a comment about how they loved how you focus on grit and resiliency, and they'd like to know if you can share maybe 1 or 2 experiences where projects haven't gone according to plan, and how do you stay resilient, and what lessons were learned from those experiences?
I was like, only 2 projects? Wow, I have to, what I think 1 is actually important, because I think it's very recent and we all are probably living through it. And I'll be the first to share. I work with an organization through COVID, and as you know, when the vaccines got released, really making sure we had a robust workflow to support the vaccination and ensure that we can get as many employees through as we could to get that done. We had our operations come to us, and literally it was on a Saturday morning. They had put in some technology, and through that technology that occurred, it didn't work well. So they came to us and they said, we really need this. So we were in the process of moving into our IS solution to kind of be able to do the scheduling, do the vaccination documentation. And we also have challenges with staffing all the various locations to maximize that while continuing to keep the lights on and caring for our patients. That's typically just a balancing act. We all need to figure out how to prioritize and work. And so the pathway we initially chose when we were speaking to our operations and understanding the requirements was not the best pathway. That's why we got the Saturday call, because it wasn't scalable and robust enough in order to support the amount of people coming in and scheduling and seeing the overlap. That's really hard when you're supporting such an important mission to protect your workforce and making sure that that's really good. So when you're calling your team on a Saturday because they have a break fix, the first thing you say to them, hey guys, just really want to thank you for giving up your Saturday and meeting with me. And I just want to let you guys, I know how hard you work day and night to get to where we are today. Based on the requirements we have, we're hearing now that we're live, these are some additional requirements that's come up. And we really need your time to focus on making this right, to help our operations not struggle with the confusion that's happening with our employees and making this a positive experience. And so we sat down, we literally brought in the operational group and we went through our lessons learned, right? What were the requirements stated? What has changed? What did we assume that we should not be assuming? And we put a detailed plan. And I would say resiliency is about applying lessons learned, having the right people there, motivating them with your end goal and the why behind why I'm asking you for this time and why this isn't a failure, but to focus on what we can do to move forward and apply those lessons learned and pivot quickly to put in great solutions. And so we literally worked Saturday, Sunday, and kind of Monday morning, it was up and running. And to me, that's a small example of some recent experience where, you know, everybody's tired. I know you all understand this and you can empathize with what I'm saying in this particular one. The second thing I would say is we actually did an EHR project. So I was actually in charge at Sutter Health for EHR project. The first go live we had, I know at the time people were like, oh, that's probably a 7. I know better, that was a 2. After the go live, I would definitely say that everything went to a pause and the teams took it so hard. But it was because the economic 2009 when it hit, that also caused that particular issue. And so having to sit down and talk to your team about revenue cycle stabilization, right? Clinical operational readiness and why some reports weren't running or why people weren't documenting data. You know, people took that hard when you're working gazillion hours to get to the go live. And so a lot of people saw that. And what you do is you put process in place, you have daily huddles, and you put action plans today. And I always say clear, concise action item, owner, and due date. An action with no owner, no due date, assume it will not get done. And communicate, communicate, communicate. A deliberate plan for execution, look at the lessons learned and turn them into tangible actions that you can do. And know that there's a light at the end of the tunnel and people will be motivated to do the right thing and work hard. Because again, back to my earlier conversation about grit and remembering why we're here to do what we do. I think when you can build that story around and give people that inspiration and motivation, you have the right operational partners, you have the right IT folks, you have the right vendor partners. We all are in it with the same common goal. We're rowing the boat the same way. Like you pick yourself up and you focus on let's learn this and let's move. And you put a plan and you deliver. I call it get it done.
Absolutely. Not everything usually goes according to plan. Not everything is a 10, right? But it's getting it done and then executing. And then if it wasn't executed to plan, it's what did we learn from it, right? How can we do better?
It's okay to be vulnerable. I've cried in front of my teams. There's no question about it. I'm like, I don't know what to do either. I trust you guys. You're the experts. I'm looking to you to help me. I can't do this without you guys. You're so important, you know? And I said, hey, I'm scared too. So sometimes just letting them, you're vulnerable. I've shed tears. Probably it could be a storm, as much tears I've shed over my lifetime on those events. But that's kind of what I say, you know, it's okay to celebrate wins. It's okay to, you know, head, heart, and hands, right, Michael? You know, hug each other pre-pandemic, okay, of course. But now you're like Zoom high five and using all your different reactions through Zoom chat or digital ways to do the high five. But really, I think those are the different ways. But I think you have a moment to self-reflect. You can have a moment to sulk and be upset about it. But it's what you do all the time that takes you back on top and get back on the, you know, get back on your game with your team because you've got good people who care about what they're doing. Put a good deliberate plan together and you just diligently work it. And you meet consistently daily if you need to make sure there's enough progress and results for the people who are depending on you to get it done.
Absolutely, absolutely. It's that communication with your team, right? I think we have another question. I would like to, ask Kevin, how do you begin the necessary discussions for an organization to embrace the need to capture sexual orientation, gender identity, and data to support the LGBTQ patient experience?
I'm at home, so if you hear my dogs bark and I jump out of the seat, just FYI, they can give me a heart attack sometimes. So that's a great question. I would say, you know, when we started this journey and I started this job in 2017 into 2018, meaningful use was sort of in its next phase. And so we were really pushing to have this questionnaire go out to all people, and we got pushed back. And we're still pushing. We're still pushing to get this sent out to people. I would love for this to go out when a MyChart account is opened, so that every person who gets a MyChart account would get this questionnaire, because we do know that the data shows that when you're asked these questions and you answer them yourself in a chart like that, you will answer them truthfully. It takes a team, and I think we've all sort of spoke to this, and it takes a team of people to get things done. You're never really doing it alone, and if you are doing it alone, you're never going to get anywhere. And so my team in IT is really the team that keeps me going with this and keeps me pushing. Glenn Doty is a great partner for me. I think many of you know him in our IT team. I love him. He and I have worked so hard to push these questions forward, and we're currently trying right now. The Perlmutter Cancer Center is really pushing forward with an LGBTQ perspective. We partnered with the National LGBTQ Cancer Center to start collecting data on the cancer experience for LGBTQ people, because we really don't have a lot of data. And so this is where the push comes from. We don't have a lot of data. This is a marginalized group of people. We need to get the information. Help us get the information. Also, when you start asking everybody these questions, they learn. They become desensitized to it. They stop asking you why, and they just answer it or say, I don't want to. And I think that's another reason to do it. But you really start to look to, again, you can't do this alone, and you really start to look to your community, right? So we have a very great partnership with Callan Lord, with APICHA, and we work together to make sure that people, especially people, this is again a marginalized community who's largely on can be on Medicaid. So to have those opportunities that we have providers that take Medicaid insurance, but the community around us helping us build this together. And sometimes we're taking their lead and they're taking ours. So that's super important. And I also believe not just our community, but our fellow hospitals. I share information with my partners at Mount Sinai, with my partners at NewYork-Presbyterian, with hospitals for special surgery, because if I find something that helps patients, I'm going to want to tell you. So that's really, really, really important. But I would say, you know, I'm going to pitch that to you, Anthony, and say that I think that is, our partnership is really important. And this collecting SOGI data is, I mean, you're probably doing it better than anybody else right now.
Yeah, I just have to, if I can, jump in and agree with everything you just said wholeheartedly. It's interesting for federally qualified health centers, and this goes back a little bit to the health policy. We are mandated by statute to collect and report SOGI data on an annual basis. And so there's a very kind of different approach to what you're describing, which is a real kind of grassroots, like build the education and promote through strategies to do outreach to patients. And I think there's certainly pros and cons to both, right? One of my favorite anecdotes about SOGI data collection was in a meeting with HRSA. It's the first year that UDS required SOGI data. And there was a small rural health center out west that in its first submission for UDS said they had 60% of their patient population identified as transgender or gender non-binary. Because they had no idea what they were submitting data about. And so this speaks to the importance of technical assistance and working with community partners that are experts in data collection around things that you may not have a large patient population that's familiar with, But I think more importantly, you may not have a staff that's familiar with something like this kind of data collection. I always go first to the front desk staff. They are often the last people that are engaged in these kinds of implementation plans, but I think the most important stakeholder. They are the ones that the patients are going to go to with their intake forms or their registration packet and say, what does this mean? And it is so important to ensure that the staff have those resources to be able to educate patients. You know, those are the staff that are going to get that portal message. I received this packet. I don't know what this question means. What are you asking me? You know, what is the difference between sex assigned at birth and gender? And, you know, like all of these questions that I think I will say for myself, I sometimes take for granted, having been working with this language for many years, is still really new to people. And I think only until we can provide that education and work, build those community partnerships and ensure that we're providing education to frontline staff that are having these interactions with patients, will we really get the data that I think we're hoping to achieve. And so just to go back, I think the SOGI data collection piece is all about education and ensuring that all the stakeholders that are involved in the data collection are at the table before you start to implement any workflows.
And I would also like to add, because we're talking about data and how the data collection is being processed, of course, through the electronic medical record. And I think from a race and ethnicity perspective, this is where the push for education in terms of the data collection really affects the frontline workers at the same time, because it ultimately impacts how we're going to quantify the number of deaths and mortality, especially with COVID-19. The recent research study done by HHC in trying to understand the number of deaths in Asian American community cannot really fully quantify if they disaggregate the data to classify it based on ethnic races, because it was not captured truly well. And you can imagine it was a pandemic crisis, right? So you're just trying to intake patients through the registration system. And those are not required fields, right? Ethnicity is not a required field compared to races. So when you're trying to understand the bigger picture of the epidemic and how it impacts each ethnic group, this is where the data disaggregation comes into play. And also all across the United States, only specific states really include ethnicity, and one of that is Hawaii, right? The other states don't have that. And again, when I was trying to explain the process on how can we understand the number of mortalities for Filipino American nurses, it's really those academic scholars, community workers, and people in the media who kind of like crowdsource the information for us, so we could better understand that there's really 30% who are affected in our community. So this is where the question of reforms and policy and how we design systems that we can truly rely on data to make better decisions.
Absolutely, and Dr. Dia, to your point, right? Let's say growing up, when let's say I personally had to fill out some forms, it was also very limited with the options that you had there, right? So it's one of those where how do we pivot and expand and grow our documentation process so that we are inclusive of those identities, right? Where oftentimes I may not see Filipino as a Filipino American, but I do see other Asian ethnicities listed. So it's how do we learn to be inclusive of all? Or what if you are multiracial? What options do you give those individuals so that they can become inclusive and also collect that data from a health perspective, right? Is there certain races or certain communities that are being affected by a specific disease more than others? So, you know, I thank you for your work in highlighting that, and to everyone on this panel as well who talk about inclusivity from a data collection mindset. There is another question. I would like to also then direct it to Michael. Michael, what tips do you have or steps do you have to take and to ensure your talent acquisition or recruiting or hiring efforts are inclusive and diverse?
So a good place to start is look at how they're done. So for example, I was working with a company and based in New York City, one of the most diverse cities in the world. And I sat down with the talent acquisition team and they were really eager to get out there and do the work. So my first question is, so where do you recruit? They said, Syracuse. I said, oh, that's great, good school. You know, they had reasons there, had relationships. And as I dug a little deeper, I realized they were going all the way upstate and not looking right in their backyard. So part of the opportunity there was looking, just expanding our reach. And, you know, some of the pushback I got back, people are busy. Recruiters are very busy and they have tough jobs. We got to give them a lot of credit for the work that they do. And they thought, they're like, Michael, we're doing so much work. We can't go to other schools or more job fairs. We can't do it. But what I helped them realize is, you know what, if we expand our reach, you're automatically going to increase the diversity of your talent pool, and it's going to make your job easier. So a little work up front is going to make your job easier. The other thing that's really important is addressing potential bias within the team, within the recruiters, and educating people. So in this case, I had a team who was very excited to learn. I gave them reading materials. We had conversations, talked about some of the issues that arose. And the other piece, I was talking earlier about connecting the dots. There was a bottleneck with hiring managers. And part of that was their biases. And relative to all the dimensions, race, gender, ethnicity, but also within the industry, they didn't want to hire somebody if their resume didn't look like what they thought it should look like. So just kind of going through the entire process, really very systematically, looking at how things are done, talking about potential bias points, bottlenecks, and just raising awareness, but going beyond awareness and giving people the skills to do better. And I got to tell you, at this organization, within 6 months, we had more diverse hires. We had more diverse promotions, because we just raised awareness and we made people cognizant and thoughtful. And they were running to me a lot, and that's okay too. But at the end of the day, I think, Pamela, you said you're the experts. They were the experts. I asked them the questions that helped them get through it and provided resources. So it's a team effort, like Kevin said. I think it was Kevin, sure. We do it together and great things happen.
Absolutely. And Pam, you know, as a CEO, right? How have you empowered elite groups to model this or to be inclusive and diverse within your company?
I would definitely say that I'm a firm believer to truly intentionally support elevating good people to do amazing work and do their very best. And when I look at diversity, as you can just hear on this call alone, diversity brings different perspectives, different ways of looking how to solve problems and bringing the collection to bear when we're really trying to solve the biggest issues or how we want to create a culture, right? So when I look at diversity, I'm like, all of those matter. Having been somebody, and Michael's already done a great job, so I'm not going to regurgitate a lot of what he's already said, but having grown up myself, I faced diversity and moving up. I've been told my English accent wasn't good enough to get to the next level. I've been told when people look at my resumes, I'm not strategic enough because I'm a get her done person. Therefore, I didn't make a good leader and I didn't qualify the next level. So I've been through all of that. And so I love some of the conversations, Michael, you already touched on, you know, regarding don't just read a book by its cover, like get to know the content a little bit. And so for me, when I formed Elite Group, you know, we are a woman minority owned firm. Truly, I wanted to make sure we were bringing world-class healthcare technology experience to bear with combining how we integrate and bring to life the greatest visions by bringing operations, patient care, vendor collaboration together. And honestly, that's why we named it Elite. L was for the French word she, that came after my grandmother, who really is a staple of my life, as you all heard. IT for leveraging IT, information technology, to really be that differentiator, right? Whether it's enabling operational efficiencies or creating competitive edge. And the reason it says groups is because you can't deliver great work if you don't collaborate and partner with the people to bring the best together. And so that's why we called it Elite Groups. We are a, one thing I would say is in our organization, 60% of my team is a leadership team. And this may surprise a lot of you, but to Michael's point, I actually have a scorecard of all the things that matter. I look at college grads who come out and give people opportunity to groom success. I wouldn't be where I am if people didn't give me a chance for my aptitude and attitude to be able to grow in my career. And this might surprise a lot of you. I literally have my teams interview people because they're closest to the front line, but I talk to every single individual that works in my company. Myself, I am the final stop. I need to make sure it's a good culture fit for what I want this company to be. That every touch and every experience people come into when they experience with my staff, that they know we're in it for your success. That's why we're here, not ours, your success. And none of your success is ever too little, too great for us to have grit, to make sure we always put you first. And so that's why I do put every detail into participating and literally being part of interviewing all the staff. And I've been privileged that a lot of people on my team have served with me for more than a decade, and they've moved with me from organization to organization. And so when I built the company to say, hey, outside of doing for organization, let's spread our ability to help so many more out there, they believed in me. And it's one of those things where, again, you got to believe in something greater than yourself that you're willing to risk it all. I don't think there's a lot of people who walk away from healthcare organizations that I'm going to do this. I have a dream and I'm going to try it. And so everything is very deliberate, intentional. Michael, to your point, is what I would wrap up is have a plan. You are what you measure it.
Absolutely. It's just taking that chance, right? And believing in yourself so that you can achieve these goals, so that you can be successful. Absolutely.
Well, I think transformational leadership, right? I mean, that is what it is. It's allowing the people that you hire to innovate, to be out on the edges, and to fostering and enabling a culture of trust does that. It innovates. And how really a non-discrimination policy truly offers you in the workplace the most diversity and finding out about others that you never would because you didn't grow up with them. That is the best thing about a non-discrimination policy, is the diversity that it offers right in front of you.
Absolutely. Transformational leadership across the board, right, Kevin?
Absolutely. It's and you can see what I know some people don't like it because it's too they need more direction. But my experience of it is that when I am working with it, it makes me just want to go. It makes me there's nothing like being trusted. It makes me want to work hard. It makes me want to innovate. It makes me want to figure it out.
There's an important word here that I'd love to share is. Oh, I think we're over.
Oh no, it's okay, Michael. Just we're gonna.
All right, I'll just throw it out there. What we're referring to here is relationship too. It's moving from transactions that we often have with organizations, with people, and really building true relationships. So the story that I shared earlier about helping the recruiting team, it was also about building relationships for the long term with communities and external organizations. And really getting to know, you're building your brand, you're building that trust with people, and they really know who you are. You're more than a transaction to them. You're really somebody who matters.
Absolutely. It's trust, right? Trust in yourself, trust in your work, and trust in everyone that you're impacting. I want to thank everyone and our panelists and our audiences, for joining us. I'd also like to introduce Tony Ferrante, our Chief Technology Strategist at AMF Innovation and Consulting. He's also our New York State Chapter HIMSS President-elect, just for some closing remarks, and I'll turn it over to you, Tony.
Alexis, thank you very much. And I'd also like to say thank you to everybody on the panel. Anthony, Kevin, Michael, Pamela, and Mary Joy, super job. And Alexis, great job in directing everybody towards it. As you can see with these great events, we have a very powerful New York State HIMSS chapter. And I would implore, if you're not part of our membership, take a few minutes, come and join us, and then come with all of the events that we're doing and see what we're putting on a constant basis. Just as a follow-up, Thursday of this week, we have another event coming up. It'll be on compliance and interoperability.
It's
March
Friday for me. It's on Friday, not Thursday.
Oh, excuse me. Thank you. Friday. I apologize. On Friday morning. And on March 5th, we'll have our privacy, security, and compliance folks will be on with an FBI agent that'll talk about what's going on with cybercrime in the healthcare. That one will not be recorded. So if you want to be with that one, you have to be on it. And then later on during the month of March, we have two other events coming up. One will be on COVID-19, the vaccinations and how that is all going. And the other one will be with a combination with one of our collaborative partners, the HFMA, and we'll talk about what's going on from the financial side in healthcare. Again, thanks everybody one more time. I appreciate it. Everybody have a safe evening, stay healthy, and get your vaccination.
Thank you. Good night.
Thank you.